can do it?
There's closed captioning.
Yeah, that's closed captioning, yeah.
Which everybody can turn on their own closed captioning.
I meant for the recording.
Well, I
Why
press
is this
record.
thing
I press
going? I don't
record.
know why this is going.
And if Zita has her closed captioning on, it should show up for the YouTube. Well,
So
I press record. I press record.
I don't know why this is going.
And if Zita has her closed captioning on, it should show up.
So can you hear me now?
Yep, but will you set me as co-host so I can press the record button unless if you're going to do that?
Something is not right
It's
here.
now it's happening with Emily's voice.
But will you set me as co-host so I can? Yeah, that's
I
because
sent you as a co-host. I guess it was me. Got
yeah,
it.
that's it. That because Zita needs to close her browser.
Okay. All right. So can you hear me now?
Yes, we can hear you, but you need to.
We're not recording, right?
Yes, either you
Hold
need
on
to
a
start
moment,
the recording,
Zita.
or I need to be set as co-host to start it.
Okay. Okay, hold on. Are we live?
Yes, we've been live for the last couple minutes now.
Okay. All right. So, like I said earlier, sorry for that whole computer online hitch, and welcome to Zita's Healthy Beginnings. Today we mark these 8 years of Zita's Healthy Beginnings existence in the United States as well as in Nigeria. As you guys know, World of Women podcast is a means that we use to reach out to our audience globally, sharing who we are and how we have been engaged with service and support to women, children, and their families. Zita's Healthy Beginnings has the whole goal to prevent maternal and infant mortality. Here in the United States and in Africa, we're starting in Nigeria right now. And we do that through advocacy, education of mothers about pregnancy, having childbirth, and how to raise their kids. We also do training of doulas, and these are people that really support women while they're, going through that whole experience. We also hope to build a maternity hospital in Nigeria as a pilot project, just to help areas in this world, especially in Africa, where we do not have maternal services that is structured. And this is our hope, that a rating staff like that will actually support mothers more. And here in the United States, where we know that we have all the structures, in fact, we have all the modern technologies that will really facilitate a woman's experience and give her a better health outcome as she tries to have her babies. We know that there are some minority population that are still not able to access this wonderful structure we have, healthcare service. And so Zita's Healthy Beginnings is working hard to close that gap, both here and in Nigeria. And this evening, we have a very wonderful doctor friend who is joining us from Nigeria. He is an obstetric and gynecologist, Dr. Samson Sule. We really got him to come regardless of the time difference, and he has offered to be with us this evening. So I am so delighted to have him. He is gonna actually uncover a whole lot for us as far as maternal health and child health is concerned. And so help me to welcome Dr. Samson Sule. Welcome, doctor, to our midst.
Thank you very much, sister. Good evening, everyone. I'm happy to be here. I'm really excited to be in your list.
Can you hear us?
Yeah, I can hear you.
Okay.
I hope I'm audible too.
We're not hearing, I'm not hearing you so well. I'm not sure if others are. If you can adjust your microphone.
Is it better now?
Oh, yeah, much better. Yeah.
So I'm happy to be in your midst. I bring you greetings from Nigeria. Sister is a very wonderful person whom I met a couple of months back. We've had very fruitful discussions aimed at helping our women through pregnancy, childbirth, and the puerperal period, because we know that this is actually the period most of them get into trouble and some have to suffer some very avoidable consequences. So it's very nice to be in the midst once again. Thank you, sister, for this opportunity. I look forward to sharing knowledge with us and also, of course, learning from the personalities in this world. Thank you.
You're welcome, doctor. And I hope your volume gets better as we go along. Yeah. So let's just jump into some of the questions that we have for Dr. Sule this evening. He is an author. He's written a book on why Nigerian women die during pregnancy. And I want to say that question book should be actually reframed why women die during pregnancy, because honestly, what Dr. disclosed in his book is applicable globally to all women, which you will find out as we move along. So, doctor, one of the questions I have for you is, please, can you define for us what is maternal mortality?
Okay, thank you very much once again, sister. Well, I hope I'm audible.
Yes.
Okay, good. Now, maternal mortality is the death of a woman during pregnancy, childbirth, or within 42 days of termination of the pregnancy, irrespective of the site and duration, from complications that are related to the pregnancy or aggravated by the pregnancy, and not by accidental or incidental causes. What our definitions try to capture is the fact that a woman dies during pregnancy. It doesn't really matter if the pregnancy is term, so long as a clinical pregnancy has been confirmed. And this death can be related to or linked to complications that have arisen from the management of that pregnancy, okay, and not from accidental or incidental causes. In other words, if a pregnant woman is involved in an accident or is unfortunate to be robbed and gets injured or loses her life while she's pregnant, such a death is termed an incidental cause or an accidental cause. It is not termed maternal mortality. So before we can say maternal mortality, we must be able to connect that death to the management of the pregnancy or complications that have arisen from it.
Thank you so much, doctor, for that definition and explanation. So I understand that, some of us, when we use our medical jargons, they do not understand. And the maternal mortality, like you said, is the death of a woman when she's pregnant and dying from causes not really related to her pregnancy. So say, for example, as you said, the woman is walking along the road and she's hit by a car and eventually she passes away. That does not count as a maternal mortality because it has nothing connected directly with the pregnancy that she is carrying. That the mortality you're talking about is the death that comes through, say, for example, the woman is pregnant and she starts bleeding, or that the woman is pregnant and ends up having high blood pressure and then start having seizures, which could not be controlled or whatever, and then she passes away through that means. That is what we count under the death of the mother during pregnancy, correct?
Very correct, sister. Very, very good.
Thank you so much. So why do women die during pregnancy? Why? Because we know that, when you look at animals, a majority of the animals, in fact, 99.9% of all animals have their babies naturally, unaided. We don't know how they do it, but we know it's the way God has made them. And in us, human beings, we are also designed to have, a woman to be pregnant, carry through 9 months, and after that, gives birth to a healthy baby. But we know in the 21st century that is not the case. A lot of women are really, dying during trying to get pregnant or trying to give birth to their babies, or shortly after giving birth, like you said. And so we want to know, please, can you share with us some of the causes of this women dying during pregnancy?
Okay, thank you, sister. When we talk about maternal mortality, we talk about a road to it. That terminology was actually coined to aid better understanding of how the journey to mortality begins for a woman that is pregnant. Okay, and it's kind of twofold. So I will try to explain it because we have a heterogeneous audience so that I can carry everyone along. Now, the road to maternal mortality begins with the delay model. There are 3 major components of this delay model. There is a type 1 delay, the type 2 delay, and the type 3 delay. When this delay sets in during pregnancy, then the woman is said to have entered into the road to mortality. Now, whether she dies or survives depends on how quickly this is identified, and then she is brought off the road. The first component of that delay model, which is the type 1 delay model, is the delay in identifying emergencies. A lot of our women do not know when emergencies have set in. They lack basic knowledge of simple conditions during pregnancy that are emergencies. And on one hand, you won't blame them much because some of these symptoms actually mimic other common illnesses or ailments that they experience. For instance, a woman who begins to convulse during pregnancy, before the convulsion starts, she usually will have some headache. She usually will have some visual disturbances. For some of them, they may have pain in the middle of their chests, what we refer to as epigastric pain. Now, in our setting, most of these symptoms can be seen with other ailments. So there's a tendency for them to think that these ailments are what they are experiencing. And then in environments where the regulation of purchase of drugs is not very strict, they go to drugstores and begin to purchase drugs to manage these symptoms, thereby initiating the delay, the type 1 delay. Such a woman that is supposed to have been taken to the hospital when she complained of visual disturbance or headache will stay at home and begin to take analgesics. Valuable time is being lost. That is delay type 1. In delay type 2, they have recognized the emergency, but they cannot easily get to the hospital to get professional help or care. This is very common in rural areas in most African countries, where access roads to health centers are very poor, transport systems are not well organized. They are more run by individuals who, depend on them as a means of livelihood. And when some of these emergencies set in at odd hours, let's say at 12 a.m., 1 a.m. in the night, when you cannot get taxis on the streets, you can't get cabs, and maybe in the neighborhood, nobody has a means of mobility. The woman is stuck at home. So there is a delay in getting the woman to the hospital. For instance, if she begins to bleed, maybe labor starts at about 1 a.m., and this woman had a diagnosis, low-lying placenta, for instance, and she begins to bleed. The husband may spend another 1 to 2 hours trying to get someone to help him get his wife to the hospital. Within that time frame, she can lose blood that will cost her life. So at such points, you talk about the type 2 delay. This is quite common in our environment, very, very common. So what we usually do is advise women to try to make arrangements for their transportation long before, they are due for delivery. But again, we know that some emergency sets in even before 10, before they are due. So they still have that delay. That's type 2. For type 3, the woman has recognized the emergency, that is, has overcome the type 1. She has been able to move herself to the hospital. She has overcome the type 2. And now she meets the type 3 delay. This delay is within the health facility itself. That is where they begin to encounter challenges of maybe non-functional utilities. Probably there's no blood in the blood bank. There's no fuel to power the generator, or there's no lights, or the health workers are on strike. Maybe there's a dispute with the government, and then the hospitals are locked down. Okay, or some staff are not on ground. Probably the government has not employed enough hands, so just few persons are manning, various wards. It could also be that the ward is filled with patients. There are no bed spaces, because we get to see that at times in some of our health facilities. They are overwhelmed. Patients have taken up all the bed spaces, and ethically it is wrong to admit patients, on the chair or on the floor. You can't do that. So you're compelled to refer them to other places. And if you are referring them at such times, before they get to where they can get professional help, time is being lost.
Mm-hmm.
The emergencies are worsening.
Mm-hmm.
So these are the 3 major ways that women enter into the road to maternal mortality. And when they are in this road and they don't get help early enough, then the risk of dying is increased.
Wow. Yeah, thank you so much, Doc, for explaining these 3 stages and 3 steps that really contribute to the women getting, into that whole road to mortality. That's really very, very true, especially in Africa. And I also know that part of that is also true here in the United States. I have actually seen some women that, they're pregnant, and we even ask them, have you started your prenatal clinic, visit? And they're like, well, I'm going to wait. I just want to make sure. And you don't know, you just don't know. So the earlier, the better. Some of the transportation issues also happen in some of the areas here where we, some encounter that kind of delay acquiring transportation, getting to the hospital on time. I wouldn't say that. I think like most of the hospitals here really are on top of emergencies. When a woman arrives to the hospital with that kind of emergency. So they're really, I must say, for the most part, we are blessed with all the technology that they apply and then, save the life of the mother and the baby. Yet we still see an increase, now in the maternal mortality. So it's something that we've been asking ourselves, why is that happening? I mean, we understand when that happens in undeveloped countries in Africa. But when it starts happening in a highly civilized nations like the United States, one begins to wonder, why is that? So we're still, probing, still asking questions and finding out that some of the things that you have actually mentioned here are also some of the challenges that we encounter here, especially when women are, trying to access a healthcare system when they are pregnant. So now let's go to the other thing. Yeah, I know you've said part of it, but that is how we can reduce or even prevent mortality. I know you have mentioned, letting the woman access health on time and stuff. So can you throw more light on how we can reduce this? Because actually that is what we're doing right now as an organization. So educate us more on the things that we can do better to make sure that mothers are no longer, dying when they're trying to bring life to the world.
Right, thank you, sister. Now, prevention of maternal mortality is the conversation is a wide one, and finding solutions to them goes beyond the health workers, goes beyond the doctors, the nurses, and those at the four walls of the hospital, so to say. This begins, or should begin, as early as possible in pregnancy or even preconception. The reason we should begin preconception is that many women have some conditions that we call premorbid conditions, some medical conditions that they probably managed before they got pregnant. Some are diabetic, some are hypertensive, some have some forms of liver diseases, some are anemic. These problems are there. But because the woman hasn't gotten pregnant, she probably may not even know that she has those conditions. Now, such can only be discovered at the preconception clinic. Incidentally, the attitude of most women to it is very poor because many of them do not see reasons why they should attend a medical consultation for a pregnancy they are anticipating. They feel it's not there yet, so what am I doing? Why don't I get it first before I begin to move? But by the time they get pregnant, then some damages would have already even started because they already have some conditions within them that has compromised their health already. So we need to begin to encourage our women to take preconception clinics seriously, especially those who have family history of some chronic medical conditions, like the instances I've given: hypertension, diabetes, asthma, sickle cell disease, liver disease, kidney disease. Because for a pregnant woman, every organ system in her body undergoes some degree of change when she gets pregnant. And if any of these systems are compromised, then it begins to worsen, makes the outcome of the pregnancy, doubtful from the get-go. Okay, that's on one side. Then the other things we could do is to begin to empower and educate our women, especially in Africa. Like I said earlier, a lot of women do not have knowledge. They don't know much. They are sort of subjected to the decisions of their husbands, of their religious leaders, of their traditional leaders. There are so many cultural practices that are inimical to their health. And they appear helpless because the culture and setting of where they stay and live gives minimal attention to their opinion. And nobody really wants to know what they think or hear what they have to say. Okay, but the good thing is if these women are well empowered and educated and they know some basic things, then they can at least voice out, when they are in pain or in such trouble and begin to shout for help until help comes. We must begin to find channels to reach out to them. Again, this has to do with penetrating some very age-long traditional practices and cultural practices, going through people that they respect, opinion leaders, opinion influencers. We must begin to help to educate women what to know, what to expect during pregnancy. When they are pregnant, it is abnormal for them to bleed. It is abnormal for them to see water before the baby comes out. It is abnormal to have headache. It is abnormal to not be able to sleep well. Okay? Not everything should be attributed to spiritual attack or wrongdoings or perceived sins that have been committed in the past. They need to know most of these things. And one other major problem we have in our setting is funding. Many of our people are poor. They cannot afford healthcare, and for most countries in our region and sub-region, the payment for health is out of pocket. Insurance packages or organizations are not widespread. They are limited to government organizations, they are limited to urban areas. But we know that most of these mortalities, they happen in the rural settings where these insurance are not available. And when you look at these women, what do they do? Some are peasants, some are traders, some are farmers, some are not even working. They're just at home, bearing children. So we have to find a way to empower them. They need to be able to pay, because even if they recognize that they are in trouble and there is no money, some of them will resign to fate and remain in their homes. And that resignation to fate would as well mean a death sentence for somebody. Okay? So funding is another challenge. Then, in the aspects of provision of health facilities, is actually where the government begins to come in. Well, for advanced countries like in the United States, I don't know, it may not be a problem, but it is still a very big challenge in our home setting here, where you have health workers that are not well remunerated, and many are leaving. The facilities, the structures may be there, but the human resources are not there. When I was younger in practice, there were some rural areas I went to work, and they had very beautiful buildings, but there was no doctor. In that same village were traditional pet attendants whose spaces were always filled up with women that wanted to, deliver. So it's not enough to build the structures. There must be hands, capable hands, trained hands available in those places to work. This is another challenge that the government needs to address. Remunerate health workers and encourage them to stay back, to stay in those places, in those rural areas, and work. Of recent, a new challenge has joined, which is the security challenge that is ravaging through our sub-region. We have heard of coup d'etats in various countries, and even within those countries, there are several incidents of attacks by gunmen, bandits, and this is not limited to the rural areas alone. They are beginning to come into even the urban areas. So people are afraid. The worker is afraid, the patient is afraid. Nobody wants to go out, right? So government also needs to provide security. And as for the patients, they need to begin to take responsibility for their health. I used to tell women, do not wait until the labor pain starts before you begin to get some things in place. For example, how do you get to the hospital? I've once had a patient, a primate, that is a woman who is pregnant for the first time. She was already in, she was 10, and she was staying alone. Her husband was working in another state, and then parents were in another state. And she was alone in her home. She came for antenatal clinic one day, and I just incidentally asked her, you're getting close to your date of delivery. If your labor starts at 1 a.m., for instance, how do you intend to get to the hospital? And she told me, God will provide. Immediately I told her that is not the Bible answer. Because at 1 a.m., if you fall into labor pains and you are alone in the house, there can be no help from anywhere if you have not planned anything before then. So I had to discuss with her to get across to one of her neighbors who has a motorcycle, and that one does it for as a business. He does it, that's his own means of livelihood. And I told her to pay some money up front and tell the man that we may call upon you at odd hours. Please make yourself available for us. So if we can integrate all these things together, and of course ensure that the things we need in our health facilities are available: blood, oxygen, lights, water, and of course the personnel to harness these resources to help people on time, we are going to reduce maternal mortality to its barest minimum.
Thank you so much, Doctor. You have really answered this question to really to the last piece of it. And I'm so glad that you have pointed out very important points, on how to reduce the death that moms are experiencing during childbirth. And this is something that is like, it's not an overnight thing. It's like 9 months plan that some women still have not gotten it in their heads, on how to take care of themselves. And for several reasons, we know it's a lack of education, like we're talking about, trying to also support them, those that have that education that aware, but they cannot afford it. So it has a whole lot, there are a whole lot of reasons why women end up the way they do, which we don't want them to happen anymore. And we're finding ways to really help them. I am hopeful that our women are listening, and those of them who are also going to listen to the recording after this podcast will really learn, because Dr. Sule has actually laid it out there for all of us to know what to do and actually how to do it. It's up to us to learn. It's up to us to take all those pieces and make sure that every single person is doing their own part, in helping. I know that family is very critical when a woman is pregnant as well. So families should be aware of their own role, in helping, especially first-time moms. It is not easy for a first-time mother, even though some of them are educated, but I have to be honest that, when it comes to any woman with first-time pregnancy, whether they're educated or not, they tend to forget. So it is the family's responsibility to support this woman, because as you rightly said, there are a lot of changes in the organs of the body, including the brain. When a woman gets pregnant, she tends to forget. don't forget that the woman forgets. So please, we're encouraging fathers, family members, grandmas, grandpas to please bear that in mind and make sure that we're really helping to support our women, because this whole thing is to have a better health outcome at the end of the pregnancy. So, Doc, I'm going to take you to another question I have here is, what are obstetric emergencies? You know, we hear about them, people talk about them, but can you explain to our audience what obstetric emergency looks like?
Okay, thank you very much. Yeah, obstetric emergencies are actually events that set in during pregnancy, at delivery, or immediately after delivery that are life-threatening and have capacity to cost life if appropriate interventions are not instituted. Now, these emergencies will be divided into two, actually. Some directly affect the baby, some directly affect the mother, while some are common to both. Okay, so I'll quickly talk about the ones that, in no particular order anyway, I'll mention some of them. For instance, obstetric emergencies will include the most common one actually is the bleeding. The bleeding could be before delivery, in which case we have what we call antepartum hemorrhage. That is, the baby is still in the womb and the woman is bleeding. Okay, and then the causes for that are there. There are quite a number of them. Then there is the postpartum hemorrhage, the bleeding that comes after delivery. That has the highest percentage when it comes to the distribution of the causes of maternal mortality globally. I think that alone is about 25 to 30% postpartum hemorrhage. Okay, so any form of bleeding at all in pregnancy is an emergency, irrespective of how old the pregnancy is. Some women in our locality will tell us, I was pregnant and I kept seeing my period. And I just smiled. All those times, what you have is threatening miscarriage that probably progress, into a complete or an incomplete miscarriage. Okay, so any form of bleeding at all is a red flag, whether it is antepartum, postpartum, or any pregnancy. The moment a woman is pregnant, she is not supposed to see blood again until after the baby is delivered. That's one. Then we also have hypertensive disorders. In this part are so many. We have the pregnancy-induced hypertension. We have those who have been hypertensive before pregnancy, and pregnancy has now worsened it. Then the ones we call chronic hypertensives. Then we have pre-eclampsia, eclampsia. They are the ones that were initially had no issues with their blood pressure. Then after about 20 weeks of gestation, the BP begins to rise alongside other organ compromise, the liver, the kidneys, So, and then of course, if nothing is done, those ones will progress to seizures, which has its own complications. Some persons actually can go blind from preeclampsia, eclampsia. They could develop stroke. They could develop heart problems for the rest of their lives if they suffer this. So anything hypertensive disorders are also emergencies. Okay. Then we also talk about cord prolapse. Cord prolapse is a baby whose umbilical cord is within the birth canal or has come out while the baby is still in the womb. That is actually an emergency for the baby, because if appropriate measures is not instituted, that is like the lifeline of the baby while the baby is in the womb. And the cord, for no reason, the cord should not come under any form of pressure or tension while the baby is in there. So, for a woman whose baby's cord has come out, the baby has to be delivered as quickly as possible. Of course, we also have other forms of emergencies like the fetal distress. Fetal distress is a baby who is in the womb and is not doing well. Okay, there are ways to detect it. They could be detected by the use of fetal stethoscopes that we auscultate, used to check the fetal heart. And if we check the fetal heart and it's not beating regularly, or it's becoming slow, or it's beating too fast, there are normal reference range for all this. Then it is signaling that all is not well within the Also for women whose babies are breech. Breech means the babies are coming out with the buttocks. Every pregnancy is expected that the baby comes with the head. But in some women, of course, there are explanations or there are causes of that. The baby does not come with the head. They either come with the buttocks, some come with their leg, which is you have the foot-leg breech. Some come with the buttocks alone. Okay? And some can actually have what we call a compound presentation. Okay? The hand and the head is coming together, and for some, it is hand prolapse. The hand is what comes out of the birth canal instead of the head or the buttocks. Now, any of this is abnormal, and when it is seen, immediate measures must be taken to deliver the baby through the abdomen, through cesarean section. So, if we have such women in labor, it is an emergency. What about those who have done surgeries before? A woman may have delivered before through cesarean section. In our setting, we do not allow any woman who has delivered, who has had more. We do not allow it. Of course, I'm aware that in some countries, we allow it because facilities are available for monitoring and intervention, decision intervention interval is short.
Right.
But we do not have that luxury in most of our institutions. There are some institutions that have it quite okay, but where these problems abound, we do not have that luxury. So for our women, after one cesarean section, we give them an opportunity to deliver per vagina once. If they get it, then they can have the opportunity in subsequent pregnancies. But for any woman who has had 2 or more cesarean sections, then all her deliveries must be by cesarean section. Now, if such women come in labor, the woman who has had 2 previous cesarean sections and is now coming in labor, which we see quite often, because most of our people are advanced to surgery, again takes us back to the drawbacks that some of our religious teachings and cultural practices, have put in the minds of our people. They tell you that they deliver like the Hebrew women, they don't need surgery. You would explain to them so much that their conditions are peculiar and they are exposing themselves to untold risk. But some of them don't believe. When you give them dates for surgeries, they don't come. As they exit your consulting room, you don't see them again. The next time you see them is when they are in labor and probably started bleeding. And some of them are actually unfortunate. Some rupture their uterus at home, and then they come back, they come to the hospital with intrauterine fetal death, that is a baby that is now dead inside them, and they are bleeding away. You have to jump and run and cover yourself and struggle to keep the woman alive.
Right.
Most times you succeed, and sometimes for those who come late, we cannot help. Okay, so for those category of people, labor in them is an emergency. Right? Then we have those who have pre-existing medical conditions that now come in labor. Some are coming from the village, they've crossed rivers, they've come a very long distance. You have no information about their pregnancy, they've not had any form of antenatal care, and they are just coming to you. Those category of patients, you treat them as emergencies because they are coming with problems which you must immediately address. Right. So there are quite a number, but for this, I think this suffices for.
Yeah. Thank you so much, Doc, for that information. That's very critical, and hopefully we're all learning and making sure that these situations are being prevented or eliminated if possible. So I would like you to, I know that sometimes we have heard in the past, especially in Africa, that was my experience, that a lot of Black women tend to grow fibroid And when they, and that starts even before they get pregnant. It has always been a problem to some, especially when they had no idea that they were growing something inside until they start being symptomatic. So can you really educate us on fibroid and pregnancy?
Thank you very much. Like you said, fibroid is very, very common among the Black women. It's often said that a gynecologist's surgery experience is not complete if he has not done a myomectomy. Myomectomy is a surgical procedure for removal of fibroid.
Mm-hmm.
It's very common. About 6 in every 10 women in Africa have fibroids. Now, what varies is the degree, the size, and the symptoms that come with it. Okay. Now, fibroids actually are innocent growths, innocent so to say, because they just develop in women. They are innocent growths that develop in the womb of women. And when they do develop, they can actually begin to cause trouble for them. Now, if we look at the, I wish I had the model here. I don't have. I would have shown us. The womb has 3 layers of muscle. It has 3 layers. It has an inner layer that we call the endometrium. It has a middle layer that we call the myometrium, and an outer layer that we call the serosa. Now, fibroid can grow in any of these 3. Some women are lucky. Their fibroids grow on the outer layer, which is the serosa. For fibroids on the serosa, we are not bothered much about them because they are far. The baby implants in the endometrium, so they are quite far away. They become problems if they are at the lower parts of the uterus, because if they are at the lower part and they are big, they can obstruct the baby's movement outwards during the day. Otherwise, if they are just small and they are on that outer layer, you just leave them. Many of them will have their babies. They will even go through labor and deliver without any problems. Now, the ones that are going to cause problems for women are the ones in the middle layer and the ones in the inner layer. The middle layer fibroids, they do not allow labor to progress normally, because during labor, the muscles of the uterus is expected to contract and retract. Those actions are what pushes the baby down until delivery. Now, when there are fibroids within this muscle, it makes that rhythmic contraction. It interrupts the rhythmic contraction. So the contractions are ineffectual in getting the baby out. If the contraction generates at the uterine fundus, which is the top, and there are fibroids along the way, it just terminates along the way. So nothing happens. So they can cause prolonged labor in such instances. Then for the fibroids that are in the inner layer, those ones are quite troublesome. Apart from the fact that preconception, they could cause massive blood loss during menstruation, what we call menorrhagia. For women who have fibroids in the inner layer, they are at risk of menorrhagia. They lose a lot of blood during their menstrual cycle, and they can come down with the complications of bleeding. Okay. Now, apart from that, for those who eventually get, to the age of or the time of reproduction, the inner layer fibroids, depending on the location, can actually make conception difficult. Some of them are located at the opening of the fallopian tubes. If they are there, conception is difficult because that means the sperm cells cannot go through the tubes to fertilize the egg. Some fibroids are located, at the space where the baby is supposed to implant. Then they cause a hostile inside environment of the uterus for the conceptus. Such women will come down with recurrent miscarriages. Okay. So usually the ones we worry most about are the ones that are in that inner layer of the uterus. And then if they are there, we usually advise these women to get them out before they conceive. Okay? For those who are able to conceive with the fibroids either in the inner layer or in the middle layer, we have seen some, we don't bother, especially when the baby is already here. The aim will now be to manage the woman through pregnancy and delivery, and then afterwards we can begin to plan how to take care of the fibroid. But again, one of the challenges we have is that a lot of people out there claim so many things that are false. And somehow, our people tend to believe these people more than us that give them care. Somebody comes on air in this era of social media, somebody opens a channel and begins to patent products, claims that when you drink them, you will shit or you will vomit or you will deliver the fibroid without any surgery. They discourage them from coming to the hospital. They paint a picture of, a snap your finger kind of solution to it. So many of our people, when you talk to them about surgery, they just agree with you and then disappear. You don't see them again until the problem starts. Okay? So, but for our women, like I said earlier, some of them, we have fibroids that do exist with pregnancy, and they actually carry those pregnancies to term and deliver. Right? For those whose fibroids are large enough to be located at the lower uterine segments, we usually advise them not to go through labor because the baby will not be able to pass. And we deliver those ones by surgery. And for those whose fibroids are in the inner uterine layer, we try our best to take care of them before they conceive. But if they do conceive, we try our best to manage them until they deliver. Then we take it off from there. Of course, there are alternatives to surgery for fibroids treatment. Again, you need to consider a lot of things. Some of these alternatives are not appropriate for women who are still desirous of fertility. They still want to have more children. So if you subject them to such treatments, it may knock out their fertility. Okay? Because some of those medications that shrink the fibroid, they disrupt the cycle from the hypothalamus to the pituitary to the ovaries. That axis that is responsible for fertility, they disrupt it. So we do not want to subject those women to such treatment. There are radiological procedures. Radiological procedures include use of some rays, okay, to burn off the fibroid. The most recent one is one we call the high intensity focused ultrasound. Some ultrasound machines are now designed that their rays are focused on fibroids in the uterus, and the rays actually burn them off. Okay? You don't have to put most of women up to compress them to bring out fibroids. There are other ones we call embolization of the arteries, because these fibroids are actually a integral part of the uterus. So if you cut off the blood supply to the uterus, you are actually cutting off the blood supply for their growth and development. And so you could embolize some arteries in the uterus, and then it will translate into shrinking and eventual drying up of the fibroid. But again, that means you are compromising the function of the uterus. So again, for a woman who is still desirous of pregnancy, you cannot subject them to those procedures. So but lay all this on the table for all patients we have, counsel them, and try to guide them to take the option that is best for their own profile, obstetric history, and then the medical conditions they may have, their age, and their desire for more children. So we try to individualize it. Not everybody will listen, but some, this was benefits. The others, we hope, come at some point.
I know. Wow. This is so important. Thank you so much, Dr. Sule, for actually taking the time to answer all these questions, providing us with all this top-notch information about women, pregnancy, and what we need to do. And I appreciate your time. And I know we're a little bit late here, but I'm just wondering if anyone has a question for Dr. Sule. Please, can you unmute and ask your question? Doctor, can you put your email address on the chat?
Okay.
That would be important so people can reach out to you. So while doctor is doing that, does anyone have any questions or comment? Okay, thank you for your information that you shared here. So yeah, like I said, if anyone has questions you want to ask right now, or since we know that we have passed our time, please send your questions. You can pass it on to me or email Dr. Sule or call Emily, call Kat. Any of us can actually forward your questions to Dr. Sule to answer. And we are, like I said, we are so blessed. We are so privileged to have him this evening talking to us about this whole important issues about women. And we know that, I mean, for any country to show that they're healthy, it's only when you look at the women and the children in that country that really determines, that's the yardstick. And we know that in some countries, they are not, the results are not really impressive, especially in Nigeria, I'm sorry to say that, and here in the United States, knowing that when you look at all the civilized countries in the world, United States is really running very below, when it comes to that. We are so high in maternal and infant mortality. And like I said, that's a concern. It's a huge concern for a country like the United States. We are number one in most of the things in the world, except when it comes to keeping our mothers healthy and the babies. And you really wonder what's actually going on. So like I said, we are still in the process of making sure we combat this whole situation. We are not supposed to experience that in the 21st century, but it is happening. And in fact, it shouldn't happen in any place around the world. But we know as developing countries in Africa, things happen. Poverty is one of them. Lack of education is another. Resources are not there to really help people to get access to healthcare services. And so we are still struggling. And I really appreciate people like Dr. Sule that you guys have very minimal resources, but you're doing the best you can. And I'm so glad that you've dedicated your life to making sure that women and their children are healthy and happy. And I keep praying for you and praying for other doctors who are in the OBGYN category. Your work is a difficult one because not only that you're trying to do your work with little resources, but the women are not, cooperating either, but they have their own issues as well. So it's really, sometimes it can be a very defeating situation. But the good news is we are working to save one woman at a time. And any single woman, you save her life and her baby's life, is a plus. And that is something positive. So thank you so much for coming. And for in the future, we're going to also have you come give us, an update of how it's happening in Nigeria and everything else. And I know you're preparing to get your exams done, your fellowship exam, and I wish you all the best. We pray and wish you well. Dr. Sule had written a book, like I said. It's called Why Do Nigerian Women Die During Pregnancy? So I am showing this book here because what we want to do right now is to make sure that this book gets into the hands of not only Nigerian women, not only African communities, but every single person. Because guess what? What goes on in a woman's anatomy is universal. So when things go on and go wrong, it's not just in the Black population. You know, so we're trying to get this book into your hands and in hands of all women, whether you're pregnant or planning to be pregnant, so that we make sure that we are fighting this war together. And hopefully we'll make sure that we win, because that's the whole idea. That's the whole purpose of writing the book, is just to make sure that we are ahead of this game when it comes to maternal and infant mortality. So if you want a copy, please, we're trying to get it online as a published publication, so people can also, it will be easier for some of us that really don't necessarily like to read a book, and they can listen, you know, make it easier. So you listen to it at your leisure time when you're driving, or, you know, like, you don't have to really handle it on your hand to read. But if you also, you know, like or prefer to the hard copies, they are available. All you need to do is just contact me or contact Dr. Sule, and we arrange and make sure that that gets to you. So, Dr. Sule, thank you so much once again. I wish you the best. And yeah, I know it's late. It's late now, but thanks for the sacrifice. I appreciate it.
Thank you, sister. I'm grateful. Congratulations.
Oh, thank you. Thank you so much. So now, until next time, we have a World of Women podcast. It's once every month, every first Tuesday. And we are inviting our friends to please share this video, share this YouTube video, and make sure that you let your friends and family watch it and learn from it. There's a lot of information here, and we are so happy that we got the opportunity to do this. So until we meet next month, I am wishing everybody a wonderful night. May God continue to support you guys, bless you, and keep you safe. Have a good evening. Bye. Okay. Emily, are you there? Julie, are you there?